All right, welcome everyone. We're just going to give folks another minute to join and then we'll get started. All right, we've got 26 participants. So in the interest of time, we're going to go ahead and get started. Our agenda today is really simple. We're going to spend the majority of our time working on an open brainstorm for long COVID data concepts. And that will be facilitated by Gay and Emma, and then just briefly talk through some next steps. But before we dive in, Jenna or Kevin, are there any comments or anything that you wish to share, or either of our co-chairs, Jerry and Katie?
Nothing from me, just Happy New Year and thanks everybody for joining.
Great. All right, we will dive in. I will hand it over to Gay.
Hello, everybody. We can just move on. Emma is helping facilitate with this, but so I think most of you have seen the next few upcoming slides. We just kind of wanted to go over the analysis process, design process for representing the data element design and identification, which is what we're going to work on today, and then design within the FHIR standard, as well as the value sets that will be used within those standards. So our goal is to leverage your clinical and caregiver expertise. We're initially focusing this call on long COVID. And then of course the caregiver with respect to that, and then we'll have another similar call where we're talking about caregiver data elements and items in particular. So after we work with you all to find to pick and prioritize the data elements, we, the EMI side, and any folks on the TEP who wish to deep dive into the standards will work together to map those concepts or data elements into the standards and leverage value sets that either exist or need to be created. Our focus again will be long COVID, as opposed to, I think, worrying about all of the various labs and things that are associated with the acute COVID state, because that's our scope. And in addition to that, there is, which I think a couple of you have seen as homework, to take a look at the implementation guide currently under ballot for the second time. That is a COVID-19 library, but that one is profile library that has value sets and very specific profiles to represent the acute COVID world. There is some longer COVID concepts in there as well, but our goal is to not redo the work, and that was an ONC sponsored initiative, and so we anticipate that, depending on the uptake and the comments, that it will be something potentially mentioned in regulation going forward. So rather than do rework, let's focus on long COVID for this one. So next slide. A little bit about exchange standards and vocabulary. There's syntax and there's semantics, meaning the syntax is kind of the structure that represents the exchange standard. So in this case, we're focusing on FHIR, and that says that defines all the attributes and elements of common concepts. And sometimes we find that there's missing information, missing attributes or elements, but in most cases, the things that we desire to represent the concept are in those structures. So you can sort of the traffic light representation is that this is the particular order of that things always go, and then the semantics are the words or the concepts and what they mean. And that would represent value sets. And so together, combining these two provides the meanings for interoperability and querying and validation and whatnot. So sometimes these elements require value sets, and sometimes they don't. Either they're already existing in the underlying standard, or they're times and dates and other temporal aspects which are part of the structure and not in most cases represented by a value set. Okay, go ahead. Next slide, please. So again, focusing on long COVID symptoms and sequelae and anything related to that you can possibly think in your mind is what we want to go over right now or brainstorm about. I mentioned before, that's a link to the COVID-19 library IG that we can, that you can sort of verify that I'm not telling you a story, that there's already concepts and value sets in there that are currently being vetted during this ballot period right now. Next slide. We are going to be making some sort of general design and structural changes in the IG so that we don't end up creating thousands of profiles over the course of what has been developed, the data elements developed over the past year, which were primarily value sets. So we're going to re-engineer the IG a little bit to make that easier to leverage all of those value sets without having an explosion in the IG. But there's a baseline structure where various attributes or elements are more specifically defined than in the US core and other based resources. And so, but our intention is to, continue with that in that path where we conform to US core and make it more strict where we need to make it more strict. And okay, next slide. So this is just a screenshot of the NN analysis spreadsheet that we'll be using, and this is just an example, not the content that's in here is not the example, but the columns are what's helpful in helping us structure our thought processes to do the mapping and to keep track of value sets that will be bound or will be listed on a value set library, if you will. And so, that we then now we're going to want to move into our brainstorming session where we hope that you guys will just, anything that you know about long COVID as a provider, as a patient, as a caregiver, what do you care about? What would you want to know about? What would you want to, communicate between your physicians or from physician to physician, clinician to clinician, caregivers, patients. And we are going to proceed through that by bringing up a spreadsheet, and next slide, please, where we are going to be capturing the brainstorming ideas. So our goal for this is to develop a inclusive, broad, and detailed list of long COVID data elements. So by detailed, I mean, first I'm thinking, well, say anything that's important to you, especially within the context of your role about long COVID. And then we'll delve into that sort of a next iteration today to describe the important details that are important about that thing for you. Like for example, if we're talking about some symptoms, what do you want to, in addition to the particular symptoms we talk about, within that symptoms, what's important for you to know, like timing, like who made the diagnosis or who is asserting that symptom, et cetera. We don't care if there's, lots of duplication or any kind of hierarchy at this point. And we will process that as we go after this call and bring it back to the next TEP call. Any questions about the brainstorming, about the goal of this, what we hope to accomplish today?
I think I would ask, just to be sure that we're clear on how you want to define long COVID, not in terms of symptoms, but in terms of duration. Since there's different standards have been used by different clinics and by different medical systems and also by reviewers.
Mm-hmm.
So I'm most acquainted with the idea of about a 5-week or more range as opposed to, say, a 12-week or more range. Okay. And I've seen different sources do different things with that. I pretty much think of it in terms of the 12 weeks, actually, but I'm sure that other people around the table probably don't think that.
Shelley, sorry,
I was just gonna
folks
ask,
are raising their
just
hand.
to clarify a little bit, but did you say that, so it's after 5 weeks, it lasts 12 weeks, or I didn't quite capture?
Well, the way some places define it is really strange. Well, they'll go 5 weeks or more, and then they'll say, well, 12 weeks or more.
Oh, okay.
I don't know if I have a strong sense of it. Certainly at Northwell, it is, if there's something that they see at 5 weeks after hospitalization, it's frequently that they're going to put that patient in that basket, long COVID basket.
Okay, great. So thank you. First I saw Shelley's hand, and then Ian, and then Aluko.
Thanks, Gay. This is Shelley Spiro, Pharmacy HIT Collaborative. One of the things that, and not to take away from what Jerry was talking about, but at least from a pharmacy standpoint, we're really concerned about which medications and which treatments have been tried, especially from a research standpoint. So we know that we're taking care of chronic patients, and now we're adding long COVID to chronic care management. What medications are related to the care of that patient that has COVID? Thank you.
Thanks, Shelley. Ian?
Yeah, thanks. With other colleagues at CDC, I've been part of lots of discussions around definitions. I think it's quite tricky. I mean, I think it depends a little bit on the rationale. So, and the kind of how you're going to use the definition. But it might be good just to simply describe, sort of to be as open as possible with symptoms. I mean, there's several challenges, right? So there's the CDC definition, which is very general, post-COVID condition. There's the WHO, Delphi consensus definition that came out recently of, at least 2 months persistence from at least 12 weeks. And then there's various other ones as well. None of these are perfect. One of the things is it's difficult to know to the extent to which it's a consequence of infection versus kind of correlated with infection. But the bottom line is someone suffering with these conditions. So I would err on the side of probably I'm biased from CDC, but capturing the data and then figuring out some of these issues later. So to be broader would make more sense, I think.
I very much agree with Ian. This is Jenna. Just wanted to jump in. I think that we should not, as a group, focus on coming up with our own way to define long COVID. I think we should figure out what are the data elements that we need to be able to capture information to help people. So if they were going to do a study and comb their EHR, they would need to have data elements for each of the symptoms, and then they would need to have a time data element. And then as our understanding of long COVID evolves, we would be able to use the data there, the amount of time the systems have lasted and the amount and what those symptoms are, to shift the definition according to what the science tells us as we learn more about what exactly long COVID is. So I would suggest that we don't specify a definition ourselves, that we say, okay, here are the things that we would need to know in order to identify a population who meets that definition or meets an evolving definition.
And I like that.
And I agree. This is Hector. One criteria should be time. I would use something sensitive enough for this. So anything that happens and continues to happen 4 weeks or more after onset of COVID could be considered. What I mean is if it lasts less than 4 weeks, we don't know what it is and we don't care. I know it's
So thank you. What I hear from that is that, well, we would need time elements are really important. We don't have to say what time, but rather we need to know when the diagnosis occurred, and then, you know, when the symptoms occurred. And so we don't necessarily have to say, you know, we don't want to know about it if it was only 3.5 weeks. We'll just be able to derive the time. Diana, you've had your hand up for time.
Yeah, sorry, I don't know how to use the hand up function. So I agree with what Jenna said earlier. I think that there are a lot of permutations that we need to consider. One are people who had asymptomatic cases and don't, you know, realize that it's COVID related symptoms that they're having for several months afterwards. And then we also have the issue of people not having any access to healthcare. So, you know, right now the average wait to get into a post-COVID care center is like 6 months at the least. So you're going to miss a lot of people. I mean, I had COVID in March of 2020, and I didn't see my first doctor until August of 2020.
Wow. Diana, I heard you mention COVID care center.
Yeah.
So tell us a little bit more about that, and you know, what does that mean to be in a COVID care center or to be identified as such?
Okay, so we actually, if you go to survivorcore.com, we have a map listed under post-COVID care centers, it's a list of all of the post-COVID care centers around the country, with descriptions of each one. I think every state is represented other than the Dakotas at this point. That does not mean that they are all built the same. They are all very different. Some are pulmonary focused, more geared towards post-ICU patients. Others are a more fully integrated system, but there's no oversight right now. There's no regulation, so there's nothing to keep anyone from putting out a shingle that calls themselves a post-COVID care center, which is one of the reasons why we need standards for these centers. A lot of them are, you know, those that are built on apps and telemedicine are generally there just to generate data, not really help the patient. I actually went through Mount Sinai's post-COVID care center, which was the first, and you know, the wait, it's almost impossible to get in. We got the CDC to change their guidance in early June and say that you no longer needed a positive test or positive PCR or antibody test to be admitted to any of these and be diagnosed with long COVID. But in practicality, none of the systems are actually utilizing that rule or that guidance because they are so overwhelmed. Another thing to mention is that there is often a significant delay between the virus and some of the neurological symptoms, the severe neurological symptoms that we're seeing. We just released a paper with Yale a couple of weeks ago on Parkinsonian-like tremors and feelings of inner vibrations, which are two of the symptoms among severe neuropathy mimicking advanced diabetes and intense gastrointestinal issues that seem to be the issues that are causing the most pain and suffering and causing the most suicide threats and actual suicides. So we've been looking at things from the perspective of what are the symptoms that are causing the most human suffering and grief, as opposed to what are the most reported symptoms.
Interesting, interesting.
Can I ask a question? Sorry, there was a lot just said. There were two things that hit me. I'm sorry, this is Emma.
Hi, Emma.
You mentioned telemedicine care, and then you mentioned admission. So post-COVID care can is it always associated with an admission, or can people be whatever amount of weeks symptomatics and not get admitted and still be considered long-term COVID long-termer?
Oh yeah, I mean, not admitted to the hospital, you mean?
Yeah, not admitted to the care setting. They've just been, they've been reporting it, doing telemedicine, doing remote visits.
They're out there suffering right now. They're out there bouncing around hopeless right now.
So it doesn't necessarily have to be tied to an admission.
But I do think it's important to capture whether they were admitted to the hospital, because I think the post-hospital effects are important to not separate, but certainly know whether they were they're going to have post-ICU syndrome or post-hospital syndrome, those kinds of things. So as we get the data set, I think it's important to acknowledge whether or not they were admitted to the hospital and how long they were admitted.
I agree. I think it's worth separating into two buckets of people. I have, from the beginning, we have really seen a different disease trajectory in long COVID among hospitalized patients versus non-hospitalized patients. Not entirely, there's obviously crossover, but, those who were not hospitalized do have lung damage, but not in the same way. We're seeing more neurological effects. I truly believe that a lot of these gastro issues are going to end up being seen as a result of an attack on the autonomic nervous system and not actual damage to the gut. I think that much of what we are looking at are neurological damage. And we need more neurologists on board. We need an integrated treatment approach. The best that I have seen in the country, there's only one that I see as being a standout. I think that the rest are all subpar. The only one that I would look to as an example is the Mayo Clinics.
Great, thank you, thank you. And Luca, just so you are aware that admission or hospitalization would be considered a data element as well. So, yeah, thanks for that. But just because it's not a symptom doesn't mean it's not a data element.
Assessing what type. I mean, one of the things that we're working with Dr. Iwasaki at Yale right now on is matching the phenotyping to the genotyping. So figuring out what are the clusters of symptoms, what are we seeing come together. We already look to see what waves of symptoms, what organ systems are affected in what timeline, and now trying to group those sets of symptoms to see what we can figure out in the clustering, given that it presents as, this panoply, as constellation of symptoms with each person having a different subset, but looking to see where we can see the trends.
Great, thank you. Shelley, I saw your hand next, I think.
Just a quick comment that I think it's important that we look and codify and probably try to expand the diagnosis of long COVID using ICD-10 codes. So, or if we need to go to ICD-11 eventually, but I think that there is a disconnect on the coding of long COVID, and I think we need to. And I hope that the CDC will, go down that path so that we can capture that information and get the appropriate diagnosis.
We do have this. We do have a ICD-10 code now for long COVID.
Yeah, but it's not granular enough to capture some of these other conditions that are affected by the diagnosis of long COVID.
Like what? What would not be included?
Well, you just mentioned some of the neurological symptoms that might be a distinguished type of long COVID. You're bucketing everything that could possibly be from a COVID exposure into one ICD-10 code, whereas it needs to be granular enough for us to go down the path, especially as we begin to identify the certain medications or treatments that we would use for long COVID.
And I think with our coding, our general, our heuristic here is to be, very sensitive. So we will, if a value set is needed in a certain area, and here we're talking about symptoms and/or diagnoses, we would create a very broad value set because we'd rather get more than miss. So that's going to be the heuristic. We don't want to limit it to codes that people might not even have in their systems. So.
Right. Another thing to keep in mind is the number of organ systems that are being affected and the number of specialties that are going to have to be brought in. My son, if I haven't mentioned this before, had a very average case, winter of 2020. At 12 years old, 9 months later, he lost one of his adult front teeth with no blood loss from vascular damage from COVID. It was written up in the New York Times Science section. It turns out thousands of our members are losing their teeth, all with no blood loss. Ocular issues are ridiculous. The hearing loss that, we really need to be very broad in but just because the symptomatology is so broad. And we have to also be willing to realize that we don't yet know the full extent. Dermatology needs to be included.
Right. Yeah, that's a perfect example of why we need to be broad, and we want more information rather than more specific things where we might miss.
So to be more systematic about this, why don't we go to the lists that are already in existence, and then because I've already heard some things that are certainly not, I don't hear about a lot from Diana, but why don't we go from the list that we already know exists and see if then others can talk about, including Diana, what's missing from those lists.
Right. Survivor Corps has from the beginning been sitting on the largest data set on non-hospitalized patients in the world because we excised the GP from the medical landscape. So where were people going to go? During a lockdown, they went to the internet to share their stories. So because I started on March 24th, 2020, we have millions of stories, which we've been able to anonymously strip and use artificial intelligence to analyze to make, because each one is basically a miniature EHR. And then we went and used the EHRs from University of California and worked with Mayo Clinic and UC Irvine and Indiana University to basically plot out all of these symptoms and really using real world evidence as opposed to just working off of EHRs where you're checking down a list, but then you're only looking for what you're looking for.
Yeah, Arlene has her hand up, and I just want to, reiterate that this is a brainstorming session, so we don't want to, we don't want to limit thoughts. And I think our follow-up for Emma and I will be to make sure that we compare it with the standardized list that, like Jerry had mentioned. But we do want to encourage any blurting is great. So Arlene, go ahead.
Yeah, so I just wanted to step back for a second and put it a little bit in the context of this project, which is to develop an eCare plan to do like patient-centered care for people who also have other coexisting conditions, and to loop back in the primary care provider who should be able to do the diagnosis, coordinate care across multiple specialists. So I just wanted to put that context in there. That this is, what we're hoping to do, and the purpose of the purpose of the eCare plan is twofold. One is to do coordinated patient-centered care planning, but the other is to collect all the data for research and to be able to collect from people in these other settings that are not getting captured. So that if this is done in a primary care office, people could include the symptoms, and then that data is available for research as well, more broadly, for people who don't have access to specialists or some of these specialized centers.
Yeah, and I think related to that, Arlene, I think a lot of the list of symptoms often don't separate out some things that we already know about how people respond to stress. like hair loss and nail changes and those
So
kinds of things.
that's not necessarily stress though. This does seem to be.
Well, I mean, yeah, but I mean, I think that it's important that we have a list that's a little bit more than just like the 200 list that we know can occur, because I do think sometimes, you know, that list can seem a little bit too much to going back to that whole care plan thing of really trying to make sure we can coordinate care for these patients. So that would be my only worry, is that if we go to the longer list, that it's going to be so long that it's not going to be as helpful.
Yeah, I think one of the things that we
once you
consider,
start
like if we would translate that into design, is we would say, you know, here's the list of, you know, here's a profile that represents common long COVID symptoms, and then, you know, say, and then have a completely open template that says, and here's the other way to represent symptoms, that where we're not, you know, just report what you've got, because we want to know.
No, but even, for example, like autonomic symptoms, there's GI autonomic symptoms, there's autonomic failure, there's autonomic hyperadrenergic symptoms. So there's there are ways to classify autonomic impairment that's not just the list of 60 things that can happen.
Right, and yeah, and that's exactly my point. You know,
Yeah,
you'd want to have a specific profile that would represent the common things, and another one that says, just tell me everything you're experiencing, basically.
I think it's having
Emily, I think I see your hand up.
Oh, hi, thank you. Apologies earlier, I was active in the chat because I had so much background noise here. But thank you again for the opportunity to share 2 points I wanted to highlight. The first is especially with this new track of long COVID, and we're kind of comparing long COVID to illnesses that we've seen in the past. I'd love to see sort of a natural history of long COVID be developed, or some longitudinal data tracking that can give us a disease course of long COVID. Like, what does the average long COVID case look like at 6 months, at 1 year, at a year and a half, at 3 months? Like, how do we compare these different data points in time? So that's one item I wanted to highlight. And then the second point I wanted to make on something that came up earlier this week for me was the broad definition of fatigue, and how I think it's really critical for this common data elements project to peel that onion a little bit and look at and help physicians and help patients define the different types of fatigue. Is it a post-exertional fatigue? Is it a muscular fatigue? Is it a brain fog? How to kind of differentiate the types of fatigue. And I think we can collectively as a medical community be better about when we talk about fatigue, how there's different factors and different presentations, and they sort of line up with different causes and different disease spaces.
Even with that though, it can still also be sleep disturbances, not just fatigue. Some people, including me, I had crazy insomnia for months and months, and manic energy.
Absolutely. I think I shared in the chat earlier about unrefreshing sleep being one of the areas we should agree 100%. Again, I think it adds to just one of the areas of the data elements we need to focus on.
I agree. And I just, one other thing is I do think that's important to keep a comprehensive list of all of the potential symptoms that people are reporting that reach a certain threshold, because I find that, you know, smart clinicians are members of Survivor Corps, because if they go in and they do a keyword, if they have a patient and they don't know whether it's COVID related, they do a keyword search in Survivor Corps, and if you get 10 answers, it's probably not related to COVID. But when you start seeing hundreds of people respond, you're like, oh, I'm onto something. This, you know, neuropathic pain, which you wouldn't think is related to what we thought was a pulmonary disease, is in fact, you know, a very common symptom. And so I think that it's also really important as a reference guide for doctors who might not have as much familiarity, because, you know, we're seeing the evidence in mass, whereas they're seeing one patient here, one patient there, none of whom are having the exact same experiences, for them to have a resource of everything to look for.
Right, and that's why, you know, that's important on the recipient processing end. And so from the IG perspective and project perspective, it's going to be, let's make sure we include that secondary profile that has, you know, really very little constraint. Just tell us what you're experiencing, period. I think I see Ian's hand next, sorry, and then Emily again.
Thanks. Yeah, I'll be brief. I put it in the chat. I think just partly for sort of data reasons, it's helpful to know the extent to which the sort of burden across the whole population is people not only experiencing symptoms, but having their daily lives impacted. So just capturing whether or not it could be binary, it could be sort of more a scale of the extent to which symptoms or abnormalities impact daily life.
Great.
Over.
Thank you. Thank you. So we've talked a lot about symptoms. We talked about the importance of knowing whether or not a patient was ever admitted. The hospitalizations, where they were, the type of unit they were hospitalized with. We talked about daily life impact.
So impact on prior illnesses. So some patients have prior allergic illnesses or autoimmune illnesses that become worsened from their long COVID experience. I think that's important.
And that fits right in with our multiple chronic care condition care plan, doesn't it? Let's see, what else have we got here, Emma, that I didn't highlight, and that we might be wanting to gather some more information about at this level.
There is something that Diana mentioned, this is Hector, I would like to go back to, which is impact on the life of the individual. Just to give you an example, some mental fog symptoms, difficulty in concentration have made people lose their work. And because even when some of these people go to long COVID centers, they are not accepted as long COVID patients. They lose any rights they have when they lose their job. It could be important, I think, to find a way to define what is a, let's call it brain fog or lack or difficulty in concentration event that is linked to COVID, because I think there is a significant problem here, and this will have implications for a number of risk-benefit and cost-benefit analysis for vaccinations, treatments, and multiple interventions, and also for how to deal with these individuals. I can elaborate if I am confusing everybody.
Great, yeah, that's interesting. Work loss due to brain fog or concentration, and then I think your other point there was if it's sort of not, but doesn't become official, then they lose, I assume, that some sort of disability, ability to collect disability.
Correct.
I see.
If they cannot attribute this to a medical problem, that person will not have the right to paid leave, for instance, or collect disability, as you said. So it would be important to be able to define it. And in order to do that, and this is not only for the brain fog, lack of concentration problem, we will have to have some limits, at least for now. I would require a positive test for us to start working, and as I said, at least for 4 weeks after onset, and a few more limits to not be so inclusive that it would be a bucket in which everything enters and it will lose its value. I'd rather have some specificity. It's very difficult, I know.
So this is Emma, and I think I'm a little confused. So are you saying that they need to have to prove having a positive COVID test? When you say positive test, is that
a positive COVID test? At least while we develop a case definition and while we develop concepts, because otherwise what we will have is a bunch of symptoms that, if we are too sensitive, we can get many people complaining for things that really are not related to COVID, that are psychiatric or others, and we will never be able to tease out what is real from what is not, what is psychiatric from autonomic or neurological, when there are no very good tests to confirm anything.
I object to that actually, because I mean, especially considering we're looking at an entirely new wave of people right now who will have COVID and have no test recorded because they did a home test. And once you get a positive home test, what are you supposed to do? Go out and get a confirmation PCR and expose everyone around you? That's not practical, and you can't just take a picture of a stick and send it to your insurance company and have it counted. So we are reproducing the exact same situation we had in spring of 2020 right now, where we are going to have a massive number of people who have no documentation of their testing. And rather than, I think it's a fool's errand, and I feel like this is sort of the rabbit hole every one of these conversations, all the committees that I sit on are, well, how are we going to make sure that, you know, that we're not confusing anxiety between just anxiety of living during a pandemic and anxiety that is being caused by COVID. Let's not limit it to, let's not start with anxiety. Let's start with the really serious physical manifestations and work backwards.
Isn't there a way? I'm really asking a question. I'm really curious.
And I agree with Emily. She just put in the chat that thank you, that thanks. Oh, my home test just arrived from Sam's Club. Another thing to think about it is in terms of equity, that you know, poor people who don't have access to healthcare, people who don't have personal, you know, lots of people don't have PCPs. They've not had the same access to testing. It's impossible to get tested right now in places like New York and Los Angeles. You know, I ordered these, 10 days ago, these tests. So we have to be really careful in terms of equity issues when we're talking about who has and has not had access to testing.
Okay.
But I mean, I think even as we can still collect the exposure information about, like, whether or not they were confirmed with a positive PCR or with an antibody or with a personal exposure to a family friend, or, I think there are ways to get at that information without necessarily requiring it.
A lot of people who have neurological long COVID do not seroconvert.
No, I'm not implying that it would be, but it would just be a way at capturing the notion of that there are different ways to come into the cohort, right? Like whether it be from confirmed or whether it be not confirmed but possible or whatever. I agree with you that I think ultimately I don't think it's functional and practical to really require a diagnosis by PCR, but I do think capturing the exposure of how they got into the cohort is relevant. I think we can do that.
So
if you're asymptomatic,
I just want to do some scope setting.
I mean,
I just want to do some scope setting.
Doctors, there's room in the CDC guidance says specifically that it is up to a doctor's discretion to diagnose long COVID. And I
would like to do some scope setting for the project, because I think we're going down a rabbit hole that we don't need to go down. I don't think we in this room need to define what criteria to meet a long COVID diagnosis. I don't think that's our job. Our job is to come up with the elements that we would need, the pieces of information that might be needed moving forward. And so I do think that having data on whether somebody received a positive test is an important piece of information, but that we should include. But I don't think that we should say, I don't think we should give any definition of what long COVID is at all. We just need to have the different elements. And that's going to be the symptoms. That's going to include whether or not the person had testing data. I think a data element potentially on self-reported positive tests might be important and something that we could discuss, right? Because to your point, Diana, you're right. A lot of people are going to have at-home tests or have not had access to testing, or in the early days of COVID when there just weren't tests available at all. So, not everybody who has long COVID will have a positive test, of course, but I think that the data element is still relevant for this project and should be included as a potential data element. So I don't want to go down though the rabbit hole of getting into how we would define COVID. I think it's more about thinking about what pieces of data people might want as they're doing research on long COVID.
Exactly. Thank you, Jenna, for bringing that scope forward. It is about, we're going to be hopefully collecting data that can be used for that information. And that's why we want to be open and sensitive to rather than, having specificity about what we will take. We want to be open to it. We want to make sure that we can gather things that we haven't thought about.
Thanks, Gay, and thanks, Jenna, for that level setting. This is Carla from the Reagan-Udall Foundation for the FDA. We had done some early work in trying to gather our community on our evidence accelerator to talk about data domains, elements, and data sources that might be important for describing post-acute SARS-CoV-2 or long COVID. And I just want to highlight that someone put in the chat kind of what I put in the chat, and somebody put up here on the screen, what those data domains might be, such as the patient characteristics, the disease characteristics, and provider characteristics that might be important, including some of the stuff that y'all have mentioned here.
Great, thank you, Carla.
Thanks.
But I think to the point that I think Henry brought up, are we going to then, we are focused on post-acute SARS-CoV-2, so we are not concerned here with kind of the impact, like mental health impacts or substance use disorder impacts that might be from loss of caregiver? I'm thinking about all the children that have lost parents to COVID. Is this not the focus of this conversation here, and kind of defining their long-term outcomes for people that are more,
Yeah, so Carla, that's a great question. And just for scope setting, so remember, this is being done in the context of an eCare plan for people with multiple chronic conditions and adding on the capacity to really diagnose and manage long COVID in the context of all the other multimorbidities that people have. And we're starting with adults. So this is the eCare, that's really important for kids, but we're actually, our eCare plan it's focused on the adult population.
I figured, but
No,
in
it's
my
good
own
to-
brain,
it's good to be
I've been like
explicit.
thinking, like, how can you not, this is also
but
a long-term
on the-
impact. Yeah, no,
But on the
totally
other
get it.
hand, there are all those other mental health sequelae, like losing your job and depression and substance abuse. It might not be long COVID, but it might be related to all the things that it's done to your life, right? So, yeah, and we definitely want to capture those things.
So both children and adults though can have mental health and substance use disorder from loss of caregiver or loss of partners and things like that, right? So it may not necessarily.
No, absolutely. And our eCare plan really does capture like all those mental health issues, and we do want to capture them, definitely. It's just we're not pediatric focused right now.
Okay.
All right, Jenna, you still have your hand up, or you want to say something else?
A legacy hand, sorry, I'll put it down.
Okay. Okay, so starting to wind up, I guess. Though I see Barrett has entered something in the chat.
Just from a multiple chronic conditions and geriatrics and aging perspective, I think function is, I heard, some similar comments, but I do think measures of function or domains of function, physical function, task-specific function, social participation function, that these are all really key context that's important in multiple chronic conditions. And if we're trying to then apply long COVID into that clinical setting, I would definitely want to take those into consideration.
Mm-hmm. Great, yeah. So and then I see that also as mentioned, the exacerbation. I think, and that reminds me because it says a key challenge seems to be how to capture exacerbation. And here we have a sort of an EHR versus standards kind of conundrum that we'll probably run into quite a lot. We can certainly define within the representation of a FHIR condition whether it's an exacerbation or not, one of the attributes of the fire condition. But the question is it actually captured in the EHR? So that I just wanted to highlight that as something that we'll probably run into. With these data elements that we're defining, there'll be a sort of a curve of what folks think is important to capture and what people are capturing in EHRs versus what's available to represent within the fire standard, and the representation most often will be able to represent far more than actually is being collected. So that's going to be an ongoing challenge, and which is one of the reasons why we have to be a little bit flexible, and rather than saying you have to have this attribute or element, because in fire, if you have to have something and there isn't that in the system, you'll get one of those 401 screens back that says there's nothing, and we don't want that. Jibril, you have a comment?
Yes, comment. I just want to throw this out for if there is a need of everybody thought to capture element about pregnancy or perinatal related data element.
That's a good point. I would imagine the answer to that would be yes. Certainly, and there's nothing new we need to create for that. There's certainly existing profiles that we can just say, hey, if you're pregnant, tell us about it, and here's the thing you use.
I want to reinforce the comment about functional limitations, not just because they're so important with regard to MCCs, but also some of what I consider to be the common symptoms of long COVID. Some of those will not come up, I would bet, from patients if they don't have a functional limitation implication. So I think we do need to think about what kind of elements could be gathered that do in fact connect to things like how people live their daily lives and things that they can do or they can't do because of some of the symptoms that you see in long COVID.
Right. Yeah. Thank you. That's good for a good emphasis. And I think if I'm remembering correctly, Jenna, some of the functional limitations I think are some of the things that we have deferred. I can't remember if that's true still.
So we had functional and cognitive status are being actively worked on by the PASC project. And so I think in our first round, we did defer them, but I do think PASC has made quite a bit of progress on those. And so I think we can likely pull, as a matter of fact, I think they have an IG currently going through a comment period, but I might be a little out of date just coming back from parental leave.
Probably not. You're probably correct. It's on my list of things to do this week. So last week, if anyone's involved in HL7 ballot commenting, is the last week to do so. The 10th, I think it's done. So
yeah, it went to a ballot in September. It actually got published.
Oh, great. Okay. It's still the last week for the January ballot for other things. So anyway, great. Okay. Let's see what else. This has been really, really super awesome. At least I think so. Just as a takeaway, we will. I'm not saying nobody else can say anything, but it is. We have 6 minutes left, so I was going to wind it up here, then hand it back over to Karen. So Emma and I will take this information and digest it. We also will share a copy of this for you folks who maybe will think of something you wish you said or didn't feel like piping up on the call to add information. And at some point, I don't know that we picked a date yet, but where we'll sort of stop having that document open for comment so that Emma and I can digest it and turn it into a productive digestion and information and verification sort of session for the next step. So Karen, back to you.
Yes, thank you, Gay. So I just dropped the link, but we'll also include that link on the Confluence page along with the meeting recording and this slide deck. So we'll get back to this group with specific dates around comments when we're gonna kind of cut that off. But yeah, feel free to include any further details or email me any information that would be helpful for us to consider. All right, and then just a quick note, our next meeting is on February 1st, so every first Tuesday of the month. I think we can adjourn. Jenna or Arlene, are there any final comments that you wish to share?
No, I just would
Thanks
love
to everybody.
Yeah, thank you. And just
Go ahead.
encourage people, if you have thoughts after this, after today, just, add them to the document or email us so that we, capture all of your suggestions.
Yes, please.
Thank
Thanks
you.
everybody for your valuable.
Thanks for a
Thank
great
you.
session. Good.
Thank you.
Bye-bye.
Bye-bye.